To another episode of Lockdown Logs. Today is day 31, and we're lucky today because we've been pushing for very long to get a medical doctor on the show, and we finally have Dr. Terence Kamal. Dr. Kamal, thank you, and good morning or afternoon.
Good morning. Well, yeah, afternoon. Thank you for having me.
Thank you for giving up time on your Sunday to join us. And giving up time on your Sunday is the least of what you've been doing since this pandemic has hit this country and the globe, essentially. I think we'll jump straight into our show the way we normally do, Dr. Kamal, and that is with a spot of news.
Covid-19 News.
Kels, you going to do that for us?
It is a spot of news. So we're just looking at the numbers worldwide. Worldwide today, we're sitting on 2.9 million people who are infected. We're sitting on 203,000 deceased.
Yep.
And then in South Africa, we're looking at a spike of quite a bit actually from yesterday. We're sitting on 4,361 today, along with 86 people deceased. And it's quite a jump from yesterday, if I'm not mistaken.
Yeah. Doc, what would you say about the rate that we've been escalating at? Because it was very controlled at first. People were actually surprised at how slowly our numbers were growing. But now it seems that we're jumping quite rapidly every day.
Are we talking the global context or South Africa specifically?
Both.
Well, both, but South Africa specifically, because South Africa was showing that super slow growth, to start with.
Yeah. I think the challenge has been, and see, I wear multiple hats. So I'm an ASAF fellow, so I'm still strongly involved in a think tank and a fellowship that involves public sector hospital CEOs and decision makers in public. But I'm also very actively involved in other communities in the business space and supporting government and corporate. The challenge lies in just the number of tests we're doing. So in the early days, and I can give you factually, Lancet could only do 1,300 tests a day. They were getting 5,000 requests. The tests were then delayed 4 to 5 days down the line. So that was a structural challenge of being able to just not do enough tests. Then there's a challenge of, for example, reagent, because these specific lab tests need a reagent to test what we're looking for. And it's an 8-hour cycle. So it's not a plug in, get a full blood count in 30 minutes to get a result. This is a complex process. So that 8-hour per cycle, and remember, the coronavirus didn't create a new test system. It plugged into a machine that also did viral loads for HIV and other related infections that we're dealing with. So we just had to piggyback on what systems we had. Then we started to get in more reagents and getting more testing systems and more people doing testing because there was so much uncertainty, but it's still not enough. Because that is where the challenge is. We're simply not testing enough. My thinking realistically is we're anything from 10x to 100x realistically of infected cases globally and in South Africa. For example, in South Africa, I'll give you an easy example. Patient A is known as a patient. He worked in a mining community or in some labor-intensive environment. He's known HIV with TB, and he goes to California because it's a hospital I know well. He goes there regularly, and he goes in now 3 weeks ago with difficulty in breathing, and they say, but you're a known TB patient, go to the TB ward. You also have HIV, we know what your problem is. And he passes away 2 weeks later. We do not have the capacity to do an autopsy or testing on every single patient that dies in a hospital environment, or he just doesn't make it to the hospital and dies at home. Nobody knows that it might have been a corona exposure because he already has pre-existing problems. We don't have first world solutions only. We've got third world problems that are structural problems. So the reality is, even the ministers admitted, we don't know the real number. We have an inferential number of what's reported and documented. But I can tell you, even in the affluent communities, and I'm talking heads of businesses, they were struggling to get testing done, even if they're willing to pay, because the labs are saying, we don't have capacity. If you think you're symptomatic, we're not interested.
Just a bit of background about you. That was extremely insightful. Dr. Kamal, you are part of, well, you're a medical doctor yourself and you've been practicing before this and that was your job. But you're also part of the YPO, which is a collective of folks just like you, super smart people, luckily. And
I would hope so.
You put them all on a platform, I understand, a WhatsApp group, and you've grown this to over 200 participants that are actively engaging in conversations. You guys have shared over 2,500 messages regarding this subject matter. And you know what? When smart people come together and talk about stuff, solutions tend to appear. Could we talk a little bit more about the YPO and what you guys are doing and which approach you're taking?
Sure. I can't officially speak on YPO, so I can speak as a member,
Right.
as a contributor, voluntary member in the organization, just from a disclaimer perspective. YPO used to stand for Young Presence Organization. That's obviously fallen away, but people commonly and affectionately know it as that. YPO was originally a US-based institution that's grown globally. It's probably, in my mind, one of the most powerful leadership organizations that exists. According to their statistics, the collective members turnover in excess of $9 trillion per annum. So it's a significant group. Getting into YPO is not just you apply, you make a certain turnover and you get it. You could tick the box on every possible criteria measured in millions of US dollars. But if they don't like you, you're not going to get it. If you don't meet the peership criteria, forget it. Each chapter has its own culture. So we have extremes of chapters who are extremely niche, and then you've got broader chapters like we have in Africa to say, if you broadly meet the criteria and we like you, they let you in. The value of such an organization is about leaders for leaders. So it's about sharing resources around things that matter to us, our families, and then our businesses and community. So as an organization, the intent is, what can we do to add value? At this point, it was about banding together. Early March, there was a question of, because we have a discussion group in which we share resources for people's various needs and conversations. And that was just purely as a support function. Anything from rugby tickets to we need to get a hold of an ambassador. It was a very diverse conversation. And the COVID group was an easy fork coming out of that saying, we need to create this. So I got in and spent most of my time. That's when I told my officers, take hold of this. Because this vertical of north of 200 CEOs employ tens of thousands of people across the country. And the reach and influence is massive. So the thinking of getting involved in such an initiative is not that I'm helping John, who's, whoever he be, but John's employment group of 75,000 people across the country that also need his leadership on what we need to do. So that entailed getting into calls at 6 a.m. to 1 a.m. saying, Terence, I've got this problem. Terence, I think this. But it was also cross-pollination between members. And to date, we're talking masks, we're talking solutions, we're talking repurposing businesses to answer the calling of what the president wants. The advantage of that is it's in a safe environment, because there's a principle in YPO that speaks of forum. So nothing, no one, never. What happens in those discussions stays confidential. And you have a tacit understanding that every person who's a member has been vouched for by his peers. So we take it as granted, not just in this country, but around the world, that you have that understanding and trust. And that allows you to focus on the bigger picture. You're not worrying about, is he going to take my idea? Is he going to steal my client? Because at this level of business, nobody's in that kind of business.
Yeah.
So that's been very, very useful. So I think it's created powerful solutions. It's created very powerful engagement with government across the board, with private sector also saying, how do we add value? Because I can tell you factually, you and I know this correctly. The release of lockdown to a different level doesn't mean we're getting any closer to a solution. Theoretically, in the data we have, talks anything from 18 to 24 months to get this under grips, if not longer.
I actually want to ask you on that note, the relaxation of lockdown legislation and the levels that we'll be following from here on forward. I'm kind of skeptical of this. I understand why it's happening. We're taking an economical collapse that we simply can't afford. However, isn't this sort of counterproductive in a way as well? Because we're really not assisting the original problem here. And if anything, we're taking a huge risk doing this.
I think it is. It's a calculated risk, right? Because the decision the president makes is, do we die from corona or do we die from starvation? I mean, putting it very,
you've
very
got to weigh those up, Yeah,
you've got to weigh that up and say, not only are we going to die of starvation today, but if this economy tanks as it has already, it's going to take years, if not decades, to recover, not our economy, the global economy. The challenge is, where do you draw the line? And that is why he's saying, let's get some industries back, because as you know, government is promising these hundreds of billions of funding. One, we don't have them, so we're going to borrow. But then how are we going to pay that back if we don't have a taxable income coming back into the fiscus?
Absolutely.
Which is exactly the call he had to make. Are we at the stage where we can afford to do it? The answer is medically no. Practically the answer is yes, because if we look at the social determinants of healthcare, we shouldn't look just at the COVID crisis. We should look at water supply, good food and nutrition, kids going back to school, losing a year of their lives, and not measuring the kid at 6 years old, but measuring him at 60 and what his financial worth and contribution to society was. So I think there's a lot of dynamics. But I think it was a calculated move, and it's a necessary move.
Yeah, I want to get back to more about what you're doing in your personal capacity, but I'd also like to pick your brain a little while you're here, because we've got so many questions. And like you said before we went live now, is I'd love to separate some myth from fact. And well, look, this COVID-19 has been surrounded by so much myth. First, it was 5G, and then it was like a created weapon in a petri dish in some laboratory in Wuhan. I think there's been so much fake news, and you'd be surprised at what people choose to believe. I'm sure you know. Now, can we talk a little bit about fact, about this crisis, about this virus? I'm not like virology and that I won't pretend to know like even anything. But in terms of a viral infection spreading this way, I don't think we've seen this in a very long time. Could you talk a little bit about like how does something like this happen? How did this happen to us? Do you know? Does anyone know?
I don't think we're going to have an honest answer very much to a lot of other conspiracies around the world of where did this start and how did it start. And I've heard extreme stories of from as simple as some random guy eating a bat and passing that on to people, to this is China's economic move to shut down the world and then take over controlling stake in key economies. A lot of those don't sound very implausible, but I don't think we have enough fact to start speculating. I think what's important at this point is not to care where it came from, but what to do about it.
Fair. No, you're right when you say that. That would be more of a solution-based view to have on this problem. The other question I've got for you, and I know we've prepped a lot of hospitals around the country, but there are also a lot of empty beds. The cases seem to be spread. I know where our concentration areas are, but where are these patients being kept right now? Do you know of any like hotspot? Have you come into contact with any actual COVID-19 patients? Because personally, I don't know anybody. I haven't heard of anybody that I know, and I don't, even know where they're being taken.
I've had actually close friends of mine internationally exposed, and very close patients that I know in South Africa. I've been at facilities in which patients are admitted in Pretoria and elsewhere, so I know exactly where they are. I mean, there's a hospital 3 km from where I live that has a positive patient that has just been discharged as of yesterday, if I understand the press release. The reality is not the 80% of the patients that will recover. It's the 20% that won't, or at risk of complications, to say the least. Not saying they won't recover, but they need aggressive medical management. I think we've got multiple factors that determine this. It's not just the determinants outside of the infection, but knowing how to deal with the infection in a time of crisis. Hospitals are empty to a large extent because of simply out of fear. Because 2 sides, the patients don't want to be there, and because we've cancelled a lot of elective surgeries and elective treatments, because it's colloquially said, and it sounds funny, but you don't want to go in there with the flu and leave with corona, or as they spoke of government in the past, go in with something and leave with something you didn't have. There are those risks at a later stage. I don't think it's a risk at this point, but I think the concern should be not about where the hotspots are, because I think that it's a misnomer of saying these are high risk areas. They're not. They're effectively testing. So if you're saying the Western Cape has higher numbers, it's most likely because they're screening more aggressively than other places.
Yeah, that makes
KZN
sense.
KZN has done a door-to-door campaign. So they've started in some communities. But again, high traffic communities, of using Durban as the easy example, there's millions of people across it, and government has said, let's start in northern KZN. A lot of those people don't travel aggressively. They are not exposed to high-risk environments. They don't necessarily work in the airports or higher transmission communities. But government said, let's start in the rural communities. It makes sense from a concentration perspective. What I don't understand enough is why would you go to a community that's less exposed? It's like going into the Amazon and saying, let's look. There is risk. But it's a question of, I think there is really good reason behind it, so I don't think it's a bad decision. But you're not seeing massive testing in Umhlanga or Zimbabwe or higher income communities in which people are traveling 60 times a year because they are at higher risk, purely by virtue of having traveled so much. Then there's the issue of stigmatization. Will somebody be willing to say, well, yes, I traveled, I have it, and I'm willing to be ostracized by my family and community? Because as professionals, that's another discussion we've had of saying, how do you manage that? Because the moment you say you have corona, it's worse, in this current perspective, worse than HIV. They're saying HIV, no, it's okay, we can handle that. Corona, nobody wants to touch you.
Yeah, but at the same time, don't you feel like it's a bit of your, look, it sucks and it's tough, but it's your responsibility if you know, look, 80% of people are recovering. And I think it's something that's not being focused on so much. So if you are someone who thinks you've got it or knows that you've got it, chances are you'll probably make it as well. I don't think it's something that you should necessarily jump into a panic into just by default.
I agree with you. I think it's very necessary.
Sorry, the delay just confused me. Please continue.
I think it's very necessary that people do take responsible decisions at this point. The challenge is, remember, we are in a mix in South Africa and Africa between first and third world. So a lot of the data we're referring to is inferential from primarily first world countries, not only, but first world, it's broadly Europe and the US. And we're making inferences from that. And that doesn't point to the circumstances we have. When you tell a guy in New York to wash his hands regularly and make sure he's hydrated and eating, his chances of getting access to food and water are much higher than a guy out in Diepsloot that doesn't have running water nor a salary outside of a weekly wage.
Yeah, no, you're right. We definitely don't have that going for us. I think the fact that we are a bit of a third world country and money is not abundant and resources aren't abundant. Yeah, it is and we've been saying this as well. It's the poorer communities and the more kind of out there communities that are going to struggle the most. We had the pleasure of having Professor Jonathan Jansen on an episode with us about last week. Not a medical doctor, of course, and so I'd like to just throw the disclaimer that he did not obviously try to present himself as such either. He had an opinion that I'd like to put forth to you. But once again, as I say, I just want to disclaim for his sake, this was just an opinion. Professor Jansen mentioned something that I found interesting, and he said we in Africa, we're exposed to a lot of things. We had the Ebola crisis, and up in Africa, there are all sorts of viral things and all sorts of other diseases that spread. And he said, what are the chances of us forming this herd immunity before there's even a vaccine? What are the chances of us kind of just toughening up?
I think it's possible. It's a discussion we've had on multiple fronts in different panels, for the last 2 months or so. Herd immunity is great, right? If your body has the opportunity, and I think it's possible. So at the outset, herd immunity is very possible. But on a contrary view to that is to have a herd immunity response. So getting exposed, and putting it very loosely, those who need to die will die. Those who survive, survive. The South African population has, on recent data, a 20% HIV infection rate, which means a large portion of those patients are at high risk because they have compromised immune systems. Then you throw TB into that, you throw malaria into that, you throw hypertension into that. Then you move into more affluent communities and actually all communities. You have diabetes, which also is poorly controlled in a large number of cases. And then you're immune compromised. And then you throw in oncology and cancer. Then you bring in pediatrics and kids and older patients who also have immune systems that may not be optimal. Then we're talking a massive portion of the population. Then you don't have herd immunity. Then you have a massacre to a large extent.
You will
lose a large portion, and if you get HIV, you have that risk.
Yeah, that's scary. That's very scary to think, because of something. Essentially, I think it's also not a choice that can be made. If this thing spreads, that's going to be, it's going to be this whole survival of the fittest concept that will come into play. I want to talk a little bit more about another initiative, but you see, when I read your press release, I won't pretend to say that I only understood about like a quarter of it, and the rest of it, I'd rather have you explain. Could you tell me a bit more about what else is going on in the life of Dr. Kamal? Because you've put I want to throw that out there. You've put your whole normal day-to-day life, your business, your practice, and you've kind of pushed this aside. You've dove head first into this crisis.
Yes. I think getting involved and being a contributor in the space is necessary, because amongst a lot of the fake news and fake noise is we found magical experts across the industries that have no exposure to healthcare whatsoever that now speak on policy decisions. And I say that with respect because everybody's contribution comes from what I believe 100% of a positive standpoint. So everybody intends to add value. And I don't believe I have all the answers either. I'm just trying to share as much as I can as I assimilate the information and digest that to see how is it relevant or not. And for example, just this morning, giving you an easy example, based on a LinkedIn conversation purely on random. It was a satire discussion that said the New England Journal of Medicine has researched President Trump's view of internal disinfectants and found it a joke. It was satire. They never did so. Somebody just made this up. But it made a good starting point to say, even if it's the New England Journal of Medicine, you need to see anything you consume with a degree of skepticism of saying, is this really valid and relevant? And I had someone out of the US come at me on a discussion saying, but have you looked enough at President Trump's view? And he has a tweet and he has this. And it would have been disrespectful not to respond because it was a very pointed discussion. And 5,000 views later, you're saying people are watching. If you respond, and you need to. So I initially responded and said, I've looked at your comments and I've looked at the data. There is no internal ultraviolet solution that you have, which is what the president was talking about at that point. And then he countered back saying, well, maybe his context was wrong, but there's a necessity of saying, how do we contribute to other solutions in healthcare? And it became a very detailed discussion of saying, very simply put, his question is, are we going to explore other things besides drugs and vaccines? And I think at that point, it was necessary to get involved and say, the correct answer is yes. But the powers that be who fund the research, who fund the government agencies, who fund the research and the implementation across the world, are primarily pharma and investors in that space. Because they wouldn't want an alternate solution. There's no focus on anything else but pharma and trials and billions, if not trillions of dollars across the world being pumped into finding that solution. But the solution's not saying...
Sorry, I'm sorry to interrupt you. I want to ask you something on that. If you say that, are you pointing to a sort of belief that there could be an alternative solution that isn't coming from pharma?
I don't think it's a pharma solution. Remember, pharma sells pills, pharma sells medication that you take as treatment, which are patents and those kind of things. But there are other solutions, which is what the person on the post had asked. His name is Bill Map, I think. So Bill's question was about, are there other solutions? For example, very much people are saying, when a patient's in ICU with COVID, can we not extract their blood into a dialysis machine, as somebody once asked me, oxygenate the blood and push it back? Practically, you could. It's not practical to try and find that many machines that do oxygenation outside of the body. So his question was, can we not extract some of the blood, treat it with an ultraviolet or an external solution, and push it back into the body? And we're saying it is very possible, theoretically, to do so. But there's no intent at this point, because there's no large volume of money to be made in saying, let's help the person cure themselves, as opposed to selling a solution. I can tell you factually, that's one of our president's concerns. The amount of money that is not going to end up in direct solutions to COVID.
I never thought I'd hear a medical doctor say those words in my life, ever in my life. The thing is, this is a topic, this is a discussion I've had off the record with a lot of people in my life, is the idea that alternative solutions are discouraged by the pharmaceutical industry because one can't profit off of them. And if you can heal yourself, or if you can actually cure something that is otherwise only being treated with medication, that's really bad for business. And I've never wanted to, I've never actually had the guts to maybe say this on a public platform, but it's been a concern to me that the pharmaceutical industry is more about profits than cures, and more about treatment than cure, more about looking at his pill, but you're going to need another one in a week. If you don't take one every week, it's not going to work out. And so every week we've got something to sell you.
I think there's a place for all of the players to be involved. But what's important is, and I won't talk about the global context, I'll speak about the South African context. We've come out of a young, and we're still a young democracy, but we have certain, pun intended, but white castles of how things are done in the country in terms of process, in academia, in terms of research, in terms of pharma, and everything that's involved. Remember when political power was handed over in 94, or, from the CODESA negotiations, it didn't mean economic control. So even in South Africa, when you talk about solutions in healthcare, we use a model that's a very Newtonian, touch, feel, tangible. I had that in 2000, and thinking back, 2003, 2004, when I put a paper at a university in South Africa, in which I had spoke of a doctor using complementary and alternative therapies that don't fit in the normal medical world, but he was a practicing pediatrician. And the university refused to accept it. They were very proud of the association with the NIH in the US. So I sent my paper to someone in the US and said, what are your thoughts on the outcomes? And they said, we like the feedback. So I sent it back to the university and said, the NIH likes it, what's your thoughts again? They said, you'll pass, it's fine. That pointed out a very simple principle. Of the controllers and decision makers in healthcare broadly in this country have been trained in a system where you can touch and feel. But in the medical world, cellular waves don't exist. In the medical world, a soul doesn't exist. In the medical world, cellular wave, not cellular, but MRIs, for example, previously didn't exist. If you told somebody 30 years ago you're going to shake a magnet that's in the brain, they think you had problems. But it was being willing to engage on saying these solutions exist outside. But the challenge we have is we live in an Einsteinian world. We talk about subatomic particles and photons and energy, but the medical world to date will only touch, feel, and test what it can physically see and demonstrate in front of them in their model. I've had many research projects where I've taken to institutions and said, I want to go into this. And the first question they've asked, and we're talking A-grade institutions in the country, they've said, who's going to fund it? Usually our funders are pharma, and if you're going to say something contrary, they won't fund it, and I'm not willing to expose my professorship to that, so I'm not interested.
That's shocking. That's I could go more. I don't have the. I'll sound very ignorant to want to go into this with you, but it's something that I do think of often, and it's something I could probably talk about very, very in depth. Dr. Kamal, what are we doing going forward? What's the outlook for us? Is it looking bleak? I mean, have we made progress? Have you made progress? How's it going on terms of beating this?
I think in beating this, what's been very positive is it's the first time in the last 100 years, in my understanding, that the world has come together collectively to focus on things that are not commercially focused, which I think is the starting point of our positivity. In my understanding, and there's different views on it, but it was nature's way of a quick reset. And it may sound very fatalistic, but it's a quick reset of saying, are we focusing on what's important? I can say that as a doctor, as an individual, as a son, as a father, that we all got very busy with unnecessary things, showing flashy lifestyles and flashy resources and traveling extensively, which is something I did quite a bit, out of necessity or not, became the focus of what we did, as opposed to what's important right now. In the Africa context, the social determinants of healthcare are important. People are still starving. People still don't have water. I lead an organization called Tolwana Accelerator, which means Fruits of Love, that implemented healthcare projects north of Mogalakwena, which is outside the platinum mines, in which these kids didn't understand the fundamentals of nutrition, healthcare, and good hygiene. And it's a project we want to carry on with corporate support. But that's where the focus needs to change, of saying, how can we impact the entire system? How can we change where our perspectives and priorities are so we can speak to what is called sustainable leadership? How do we make money, but also contribute to stakeholders or not shareholders, which is something the world's been talking about for decades. The World Economic Forum has had that. Professor Schwab has spoken of stakeholder capitalism, which, whether it's Greta or anyone else, is saying, I have an interest in what you do, whether I'm your shareholder or not. That is where the positive of this is coming out. Because for years, and right up to January when I was at Davos, it's talk, but everybody leaving with a commercial transaction. Now the focus is we're in this together. And we've got to find viable solutions, not just for the corona crisis, but going forward. Because if we're trying to solve corona, we also got to solve malaria, HIV, TB, nutrition, healthcare, and fundamentals across the system. You and I know NHI has been a big discussion in South Africa. And there's been massive resistance from private saying, we'll work with government, but we have reservations. All that's fallen away. We're currently in an NHI test phase where we're working together to say, we're here to save lives. There's no commercial focus, or there may be some commercial focus, but the perspective and lenses change. However, realistically, on the immediate concern, corona is here to stay for a while. Even if it's vaccines and early stage trials, it's going to be months, if not years, before we find viable solutions. Guys are talking 12 to 18 months. I'm thinking closer to 24 months. But in that period, we've got to do what we can as individuals and as communities, not just for ourselves, for those who don't have a fighting chance, those who don't have the basic necessities. And I say that outside of being a doctor, as a human being, how do we go to sleep knowing we've got, and it's a simple example. I go to the fridge when I'm in the evening or when I'm going to read email, and I've got something to snack on. And the question is not what to eat, but what to choose to eat, versus an individual who has nothing to eat in this country. Yeah. Yet we're equally exposed. And I think those are the dynamics we need to be focusing on.
I think the scary thing as well is just how close those two live within one another. I mean, in our town, we your neighbor could be in a very different situation to you with regards to what you just said. Yeah, I think there's been a great show of humanism and, the most unlikely of organizations and corporations have shown a human side and said, well, look, we're going to give without necessarily expecting anything back. And that's amazing. I never thought I'd see that happen. And I think if we can sustain that going forward, we've been having all sorts of kind of philosophical talks about the whole broader spectrum of what this can do. And we've been trying to focus on a lot of the positive things that have come from this. Everybody being cooped up in their houses. We've heard of all the environmental changes that have taken effect, good ones. And it got us talking about, are there certain things that we should look at not going back to normal? We shouldn't go back to what we were doing. I think this is a good chance to perhaps reevaluate how we were doing things just to start with. The way we've been, like you said, traveling excessively, creating a lot of gases and all sorts of, and the gases are the least of it. It's also the part that I kind of understand the least. But not just that, thousands of people communicating with each other, coming into contact with each other where it wasn't always necessary. That kind of thing where the meeting could have been an email. I think a lot of things could be emails.
I think that's where we've been pushed into this environment. A lot of the meetings I've had across the last 2 to 3 years have been primarily virtual. So I've had situations where you've got 12 to 15 countries on a call. You're making quick strategic decisions, and you have a once a year face-to-face contact, where as the chairman of one of my boards says, a beers and pizza kind of conversation. Can I trust this guy? Can I meet the individual beyond the screen? that is still necessary. The human-to-human contact, it's a primary need that we have as humans to interact and bond and share time. But do we need to do it as often as we said we did? I think that needs to change. I think the motivations and the underlying motivations need to change.
Dr. Kamal, from my side, I could ask you probably 1,000 things, but I can already tell you you're going to be invited back sooner than later. And thanks again for taking your time on a Sunday. Kelsey, from your side?
Yeah, sorry, I've been very quiet. I've actually been listening to everything you guys have been saying because I have no idea or any knowledge in this kind of field with regards to what you guys are talking about. So it was interesting to hear about it. So thank you. Thank you very much.
Thank you. I don't think it's about expertise at this point, right? It's about having a curious mind with a high degree of skepticism, because there's a lot that's going to come to the fore. We also got to be realistic and ask ourselves, what is genuinely valid? And even if it's valid, how is it relevant to me?
Yeah, no, you're 100% correct. Dr. Kamal, thank you.
Thank you, Doctor.
Thank you for having me. It's been such a pleasure.